So now let us go to a different subset of patients where hyperkalemia is a problem. After giving drugs like RAS inhibitors or MRAs including ARNI, how do we manage them? So before you start these patients on these drugs, you check their potassium levels and see what is the range. If the potassium is already above 5, then try to find out what is the reason of that. Many a times you will see that patients have high potassium diet. They feel that high potassium diet is good for hypertensive patients, keeping the sodium low. So they will have fruits, fruit juices, bananas, oranges, they will have dry fruits, dates, almonds, walnuts, pineapple, all these fruits and dry fruits or wet fruits, they increase the potassium levels. So first of all, the diet itself can reduce the potassium by 10 to 20%. As I said, we have to try and accommodate ARNI in these patients. So one has to be extra enthusiastic in finding out the causes of hyperkalemia. Maybe you have to give a small dose of diuretics so that the potassium goes less, and then you add ARNI to that. Because both are the recommended drugs for heart failure as one of the pillars. So as I said, one has to be careful. Try give small dosage. ARNI you can give 50 half BID. Once they become stable on the potassium levels, maybe reaching 4.8, 4.9, and with all other dietary and other drugs, diuretics, then add a small dose of MRA. I sometimes try half the tablet alternate day, 12.5 milligram of eplerenone alternate day, because eplerenone reduces the potassium less than the aldactone. So try that drug instead of aldactone and try and adjust, keep a watch. After 5 days, ask them to check the potassium levels and see that the potassium in the diet is less, both in fruits, vegetables and dry fruits or other drugs. They should not be taking that low salt which you get, a substitute for salt, where the potassium is high and the salt is low, the sodium is low rather. So otherwise, if they are acutely high potassium, you can give potassium binders, you can give asthalin sprays, you can give glucose insulin pumps and decrease the potassium acutely. You can give IV calcium gluconate, soda bicarb. Very rarely, if they come in an acute emergency, you have to put in a temporary pacemaker. But otherwise, by and large, it can be managed. The only caveat I have seen is you have to educate the patient that with this drug, potassium will increase. I have to keep a watch. Please check your potassium after 5 to 7 days and send me on mail or WhatsApp or any other way so that I know how to adjust the drugs. So this is what I do for hyperkalemia with ARNI or MRAs. Thank you.